To this press conference to go over the situation in Quebec about COVID-19. The Premier of Quebec, Mr. François Legault, is as always with the Minister of Health and Social Services, Ms. Danielle McCann, as well as the National Director of Public Health of Quebec, Dr. Horatio Arruda. Mr. Premier. Hello, everyone. I will start with the day's numbers. Unfortunately, we have 102 new deaths, a total of 1,041. I want to, of course, offer my condolences to all the families and loved ones of those victims. We now have 20,126 confirmed cases. That is an increase of 807. We have 1,224 people who are being hospitalized. That is an increase of 55. And of those, 201 people in ICU, an increase of 3. Of course, the great challenge remains in our residences for the elderly. It is important to mention that out of the 1,041 deaths that we've had up until now, 850 of those were people who were in the different residences for the elderly. Many died after being transferred to the hospital, but where they came from, 850 out of 1,041 deaths who came from those residences. So that truly is where the challenge is, the 2,600 residences. It is, however, important to explain the situation in those 2,600 residences. First, out of those 2,600 residences, there are CHSLDs, both public and private. There are RPAs, there are intermediate resources, or RIs. There's 2,300 out of 2,600 where there are no cases of COVID-19. So that does mean 2,300 out of 2,600, there are no cases. In those 300 where there are at least one case or more of COVID-19, it's important to say that there's 220 residences out of the remaining 300 where the situation, we calculate that it is under control. So that means that there are 80 residences out of 2,600 in total where the situation is more difficult, where we have more attentive monitoring that has to be done. Some good news. Out of the 2,000 employees that we were missing, as I said yesterday, and I've been saying for a few days that we were missing 2,000 employees, yesterday we got specialists, doctors, both generalist and specialist. We got nurses, students, orderlies who confirmed their work, the vast majority full-time. And so yesterday we managed to fill 1,000 of the 2,000 positions. And we trust that by tomorrow, with all those who have signaled to us, we should be able to fill the 1,000 missing people that we have left in the 2,600 residences, which means that if all goes well, by tomorrow evening, the situation should be under control as far as the staffing issue is concerned. Of course, I wish to tremendously thank all those doctors, nurses, orderlies, healthcare students who have accepted coming to work full-time. This is a collective effort that we are waging. It is courageous because it's not always easy, as I was saying earlier on, particularly in the 80 residences where things are more difficult. However, there are people who have accepted coming to work, and I can only be in admiration faced with this situation. One point that I wanted to touch upon, I read and heard a lot of comments on the fact that we are transferring staff, whether it be doctors or nurses, from the hospitals and transferring them towards residences for the elderly. First, what's important to say is that the emergency truly is in those residences. When I say that of 1,041 deaths that we've had, 850 are people who came from the residences, that means that there's a lot of work that has to be done there. But what is important to clear up is that we have not delayed any urgent activity in the hospitals. So for the past month, the decision that we made in order to prepare ourselves because of COVID-19 is to free up about 6,000 beds out of the 18,000 beds that we have available. That means that there's still 12,000 beds where there are activities going on in our hospitals. And all those urgent activities will be done. And gradually, as we have staff that will be added, students and others, will be able to free up specialists, doctors, who will be able to gradually, over the next few weeks, start again having a full load in order to be able to reuse a part of the 6,000 beds that are free in hospitals. So, however, there is a problem that is rather particular right now, and that is the world scarcity of sedatives. Propofol. There are medications or alternative techniques, but they are not as efficient. So the number of operations, the number of surgeries that can be done becomes more complicated. So we're looking for solutions, we're working on that, but just to let you know, we are no different from everywhere else in the world. There is a dearth of medication like propofol, so sedatives, to be able to make people sleep, call it how you will, but people who have to be operated. I'd like to come back to the situation. So out of 2,600 residences of all kinds, there are 80 where things are a little more, actually not a little more, but quite a bit more difficult. But what it is important to say is that in the rest of Quebec, both in Montreal and other regions, the situation is pretty stable and has been for a certain number of days. So we are having a look. We're having another meeting tonight. We are having a look at how we will be gradually reopening the economy, the schools, and daycare centers. But the important word here is gradually. We wish to be quite certain that we continue having stability for a certain number of days or even weeks, and we want to go gradually. And I want to say a word on the schools and daycares. And I'm talking about only the health aspect. I'm not talking about the economic point of view here. I'm talking about the health. It would not be a good idea to wait for the 1st of September to send 1 million children back to school at the same time, with the risks that there is contagion with their parents and that there be a lot of people sick at the same time, which would create a second wave of COVID-19. So just to let you know that what we're looking at right now is a gradual reopening. So over the next few weeks, over the next few months, gradually reopening the economy, daycare centers, schools, but to do it gradually, we are consulting with my caucus, our 76 NMAs. I talked to the 3 leaders of the opposition. They are also going to be consulting their own National Assembly to be able to talk about it. So the idea is not to go quickly, it's to go gradually, and the criteria being used is health. I want us to protect our children, our educators, our teachers. I want everyone to be safe. And I repeat that it would not be a good idea to send all those people at the same time in schools and daycares together. We have to go gradually. Speaking of reopening, another good news, the UPA, so l'Union des producteurs agricoles, the agricultural union, are saying that they're overwhelmed with calls from both young people and not so young people who want to go work on the farms this summer. So very, very happy to hear that. I know that it's not easy. I did it when I was young at McDonald College in Saint-Anne-de-Bellevue. I went to pick strawberries. The first few days, it was really hard on my back. Pretty hard to be stooped over all day. But it's a really nice experience. You're outside. I see that there are journalists who are interested. It's open to you too, if you wish. So I think that it is important, and we've been saying it for a few weeks now. We wish for Quebec to be more autonomous in terms of food, and that means that we need to have more people in our farms, in our fields, and I want to take advantage of this opportunity to thank our farmers. This is hard work. They are there year-long, and it is thanks to them that we have fresh produce, local products in our groceries, and so that is my daily thanks. So I would like to conclude by saying, let's keep going. We will get through it together. Thank you. English.
Good afternoon. We continue the deployment of health workers in senior residences. We have physicians, nurses, health students that are coming, adding to the people working in our senior residences, and the situation is getting more and more under control. It's important to say that outside the residences, the situation is stable in Quebec. Of course, we still need some time to be sure that the pandemic is under control before reopening the economy and the schools. We have to do that gradually with the okay of Dr. Arruda. And as soon as we'll get the okay of Dr. Arruda, we'll table a plan to tell you exactly how it will be done in the next weeks and months. So we must not give up. We will get through this together. Thank you all.
Merci, Monsieur le Premier ministre. Alors, pour la période des questions des journalistes.
Thank you, Mr. Premier. We are now going to start the question period.
Bonjour à vous trois. Plusieurs régions sont
Many regions are, as you said, not very affected by the coronavirus. Will the deconfinement and the reopening of businesses, could that be done quickly in those regions in order for them not to be penalized by the amplitude of a crisis that is mainly affecting Montreal and especially the residences for the elderly? Which regions could open first? Well, that is part of the scenarios that we are studying right now, to start by opening certain regions. You know, the businesses, the daycare, the schools. But there is nothing yet that has been decided. We do want to make sure that for a certain number of days still, that the situation does remain stable. So in order to be clear, I have not yet quite gotten the okay from Dr. Arruda. So over the next few days, we will continue having a look at different scenarios. But yes, among the scenarios that we're thinking of, there is a possibility that businesses, daycares, and schools of certain regions will be open before others. Yesterday, you postponed the reopening of schools. If the schools only open later in May, is there a scenario of prolonging the school year beyond Saint-Jean-Baptiste, or to go back earlier in the fall? There's a lot of scenarios that we're studying, and nothing has been decided as far as the school year is concerned, and of the work that will have to be done when we go back to school in September. There's a lot of scenarios. It will, of course, depend on when we reopen the schools. First, is it correct to say that you have the intention to go back to surgeries that operation room work at 50% of their capacity over the next few days? It's something that we are looking at, yes. But for the time being, what we need are the specialist doctors in CHSLDs. We have asked them to come and work for a 2-week period. After that 2-week period, and even for a certain number of them, we are thinking that it may be possible over the next few days or weeks to gradually increase the surgeries, so of having a rhythm that is more sustained than the 4 past weeks. Now, as far as the situation in general is concerned, in the past few weeks you did a lot of comparisons with elsewhere. And we're talking here about deconfinement if the situation remains stable, but we are still at confirmed cases of COVID, whereas the screening is limited to the people who have been ill and the healthcare sector. So 800, 900 cases per day, whereas, and yet we're confined, as you know. And we have deaths still. So like it's 100 per day now. And it hasn't stopped increasing. We are leaving the optimistic scenario. Is that not concerning? I don't think so. When we look at the two scenarios that we had given, the optimistic and the pessimistic, we're much closer to the optimistic one rather than the pessimistic one. Now, there are many things, and I'm sure that Dr. Arruda will be able to add a lot of it to it. So out of the 1,041 deaths, 850 are people who came from the residences where there is a specific problem. Now, of course, deaths are one thing, but before then, there's the number of cases. There's the R0 that Dr. Arruda likes to talk about, that is to say, how many people are infected by one infected person. There is the situation in hospitals. On that front, we had predicted using up to 8,000 beds, and we're using about 1,200 right now. So that remains very stable, and that is an important condition to reopen the economy gradually, as well as the schools, because we don't want for a new wave to come and overwhelm and to find a situation where we would lose control in the hospitals. That was the main objective of the confinement, was to delay the arrival of a big wave in hospitals. And it does not seem that there is going to be that big wave that we were expecting. There is that situation in CHSLDs as well as the residences, but it's all those numbers that are being examined by the scientists, by public health authorities. Maybe if I could add, the Premier said the essential part of the information, but you have to see that we are facing three epidemics, if you will. The greater metropolitan area epidemic, which is at once community, but very driven by CHSLDs. If you remove the CHSLDs from the curve, it also changes. And there is a transmission in what we say Zone 2, which has certain areas around the Montreal area and the central Quebec, and then you have the greater north area. Facing this different epidemiology, how do we, if we exclude the CHSLD, because we don't want to export that in other regions, that is what we are working at very hard, but we are able to get, and we're following, despite the fact that it has stabilized in terms of death, but really associated to CHSLDs, not necessarily in the community. I mean, there are some, but it's not just associated to that, because there are also people, who are dying at home in the elderly. So we already are observing a few other cases in the 50 to 59 age group who are not always hospitalized. So that is also a possibility. So with that portrait, we're going to see, epidemiologically speaking, if there's a decrease of cases, of hospitalizations, and ICU needs, then we'll be able to open up, what I would call the dimmer in function of the local epidemiology while retaining important social distancing within the society in order not to amplify the phenomena. So that is our purpose. I would like to be certain that I've understood the situation correctly in hospitals, because last week you had told us we are continuing to free things up for about 2 weeks. We want for doctors in CHSLDs. But now you're thinking about reopening the surgeries more quickly? There are many people in the healthcare sector that are finding that the message is perhaps a little confused, that you announce a guideline and we set it up and already it's being changed. In fact, is it clear what's going on with freeing up of activities? Are we going back? And what is happening with the doctors that are already in CHSLDs? Are they going to be going back to the hospitals? I'm going to let Danielle complete, but I just want to say that generally speaking, we have, in order to be able to face the potential arrival of COVID-19 patients, we offloaded certain activities for the past 2 weeks and will continue doing it for 2 weeks, which means that a lot of people, including some specialists who were available in hospitals, were taking a part of those doctors, those specialists and the nurses that are used to working with these specialists, and we sent them to CHSLDs. But there's a part that remained, and now we're going to have to look at it specialty by specialty. Cancer cases, cardiology cases, that, people are staying in the hospitals for the most part. So we have to take it specialty by specialty. So we are saying that we're going to continue offloading a part of the activities for a 2-week period. But despite that, there is a possibility, even when we take into account that transfer to CHSLDs, there is still a possibility of having a certain number of specialists who could gradually increase their activities. Yes, the specialists who come in CHSLDs are doctors who are inactive because we offloaded, big parts. A lot of them are elective surgeries. So they haven't started again and they're not going to for a while. When we say that we are gradually increasing surgeries, we're talking about semi-urgent emergencies, so the ones that have priority. So the specialists who are coming in the CHSLDs, there is no impact on those activities at the hospitals. None. So, as the Premier said, we are keeping the same level of activity in a hospital setting, but even in the context where there are specialists who are coming to CHSLDs, there are others who are available and who will be able to start increasing the number of surgeries. And certainly we have to look at the semi-urgent surgeries and we have to go forward with them. So we have a situation as far as the medication is concerned, which is difficult. Sedatives, but we're managing it well, I believe, and we are in communication with our suppliers. And that balance makes it that we can reopen surgeries, the semi-urgent ones, a little bit, because, they are also becoming more urgent because it's been a little bit over a month, and there are surgeries that won't be able to wait longer than that. So we'll be able to do that. And I want to send the message that I sent yesterday again, to tell the population that, yes, we are treating people with COVID-19. That's very important. But we're not forgetting the other ones. We're taking care of them, and the evidence is that we have 11,000 people in our hospitals right now that are being treated for things other than COVID-19, and the doctors are there for them. And you have to call them, and if you have symptoms that could be very problematic, you have to go to the emergency ward, whether you have, if you think that you may be having a stroke, go. There are teams of doctors that are there for you, and those activities are continuing in the hospital setting. And we really want to respond to all needs. So obviously, COVID-19, that's obvious in CHSLDs, in hospitals, but we are able to also respond to other urgent and semi-urgent needs in cancerology and anything that is very important in terms of health sectors. And just to give you a few numbers, we had 18,000 beds that were used in hospitals. We freed up 7,000 of them, which brought us down to 11,000. Now there's about 1,200 that are being used for COVID-19. So there are about 6,000 left, a little bit less. If tomorrow morning we decided to go back up to 13,000 or 14,000 or 15,000, we'll have fewer activities as usual when we usually have 18,000 beds, but it could be more than 18,000 because the space that we had given ourselves for COVID-19, it seems that we will not need all that space for COVID-19 in hospitals. Therefore, you mentioned in an introduction that there was no urgent activity that had been delayed in hospitals, but yet we learned today, and it's the Association of Cardiologists that made a compilation, that there are people who died because care was not brought to them. There's the example, for example, of a lady who was 60-some who had a stroke after her operation was reported. There are sources in oncology as well that says that there were operations for certain kinds of cancers that were postponed, certain patients that are given longer chemotherapy treatments to be able to get to be able to have surgeries later. So are we quite sure that there's no impact on healthcare? Are you quite sure that that is being concretely applied in the hospitals? Well, listen, none of us safe from a situation that we would have wished to avoid. I think that we're all human. But at the same time, I have to tell you that all the precautions are taken. We have set up clinical committees to do follow-ups, and I speak to the Deputy Minister for Hospital Affairs every single day. And I spoke with the National Director of Cancerology yesterday. These are clinical committees that get together every day. They do follow-up every day. So there's a part of that where, as I was saying earlier on, people have to get in touch with their doctors if anything develops. But chemo, radiotherapy has been continued. Those treatments have continued. It is true that we gave certain alternative treatments to surgery. Yes, it's true that we did that. And there are evaluations of all the semi-urgent situations being done. So, of course, we truly want for the entire population that has needs in terms of all those spheres of activities, which are cardiology, cancerology, even urology, that all those spheres of activities where they have needs, that they call their doctors, that they go to the emergency ward if they have worrisome symptoms. And we do these clinical evaluations every day with our teams, with the DSP, with the ministry. Everybody is in contact. And we have protocols as well that are very, very clear on that in different situations that are being followed to the letter. So we really hope that we won't drop the ball on any case. I would like to have the specific cases that were mentioned because the guideline has been clear since the beginning. There is no question of delaying any activity, of postponing anything that is urgent and that could endanger the life of a patient. There's never been question of that. Was there an error in the evaluation? I would like to have the detail because there's never been any question of postponing any activities that would endanger the life of a patient. I'm told that there's a guideline that was given this morning, and I could give you the name of other committees, but the COVID-19 committee for the Montreal, that operation blocks had to be reopened at 50%. So has there been that guideline that was given this morning for that? And there are doctors that communicate with me and who tell me that it's not clear what has to be urgent, what is supposed to be semi-urgent for them, for surgeons who are doing operations in oncology. They're saying it's not clear in our minds what is considered as being urgent or semi-urgent. So could we have clarification on that? Because you seem to say that everything is clear, but the doctors who speak to us are telling us that for them, they're confused. Well, listen, it's, it's clinical, and we've never had that situation before. So I talked for a long time to a doctor in cancerology who explained to me what the protocols were and how it's applied. But I won't keep it from you that there are concerns on the part of doctors because it truly is a situation that we haven't encountered before. But what I can tell you today is that the clinical follow-ups are done very systematically. The protocols, I see them. The cancerology protocols, as much as possible, the clinical protocols are given to the doctors. So those protocols have to be followed with those departments within each establishment. And that's pretty much what we can do that is the clearest because we had to review things in the present context. And you're right to say that what is semi-urgent, that is something that has to be done practically every day because the situation of people can change. You can be semi-urgent a week ago and become urgent 2 weeks later. So that is a challenge. But I think that the clinical teams are trying to do the very best. And it is daily work that has to be done with the clinical experts. But the protocols are transmitted and the protocols are written black on white. But it is in the reality that you have to be able to get in touch with patients and the patients have to be able to get in touch with their doctors if the situation changes. So are you telling me that there were cases that were considered to be semi-urgent, so that they had to be operated, that were left aside and became urgent and then they were operated? That you therefore let a situation of certain patients become more serious to then operate them? Because what doctors are telling me is that this is what happened. Well, we'd like to know. as the Premier was saying, I would like to have that information. Who are we talking about? What are we talking about? Because when I say semi-urgent, I'm talking about situations, for example, there might have been alternative treatments that were given rather than surgery. That is something that may take place. But we have not left an emergency situation. We haven't let somebody not be operated who urgently needed it. So if there are situations that you're aware of, we would like to know this. In an establishment in Montreal, I made a verification where I heard these kinds of concerns, like the one that you just mentioned. We went right to the source, and it was not the case. So we like to have the information. We want to have that information, absolutely. Mr. Premier, so there's a period of about 2 weeks to be able to fix a national emergency for people who are going to go help out in CHSLDs, but what will happen after that delay? Is the problem with the scarcity of staff, is that going to be fixed as far as you're concerned? Do you think, or could the delay be prolonged? Well, listen, right now there's 2,000 people who are absent. Some of them are infected, so we hope that they will get cured and come back. There are some, I've been told, many who no longer have any symptoms, but we're respecting, the 14-day period before those people go back. There is training that is given to students who studied in the healthcare, who are gradually being integrated in the CHSLDs. So we believe that gradually the situation should improve in CHSLDs. So there should be, eventually, within 2 weeks, fewer COVID-19 cases in CHSLDs. So that means fewer requirements on the staff and less pressure. So we believe that over the 2-week period, those doctors that accepted coming in CHSLDs could go back to hospitals. Let's talk about orderlies again, but the ones that work in the private residences, so the RPAs. As you know, they are paid even less than in the public sector, and you're offering them right now a temporary premium, but that will only last a certain time. They are asking the setup of a decree in order to fix minimum conditions in the sector. Are you open to that? Jean Boulet is looking at that. But of course, in increasing the wages of the orderlies in the public sector, in the public CHSLDs, for example, that is going to put pressure on the wages in the private sector. We understand that very well. There are places where the government buys, so we'll have to give more money to be able to purchase those places, those spots. So we can see the domino effect here. But the first step is to be able to fix the wages of those orderlies in the public sector. But I was talking with the president of the Treasury yesterday. We're making an evaluation of the cost that it's going to bring in the private sector. Now, do we have to fix the conditions in each private establishment? Maybe. But the situation could be different between a private intermediary resource, for example, or a private RPA, or a CHSLD that is private. So we can't either go into the hyper-bureaucratization of the wages, private, public in those residences. Thank you. Your non-verbal talks a lot, Mr. Legault. When we talked about operations in the hospitals that had been postponed, that there were cases. Right now, I'd like to come back with this question. Do you have right now all of the information to be able to make your decisions at the highest level of the hierarchy, or is the bureaucracy so burdensome that it doesn't allow you to have all the information? I think it's more a question of evaluation and of judgment. What is an urgent activity? What is a semi-urgent activity? We've been clear since the beginning. We thought that we could free up 6,000 beds in order to be able to welcome patients with COVID-19 in hospitals while maintaining, with about 12,000 beds, the urgent activities. This is not something that is, can be done without going on a case-by-case scenario in certain cases. There are doctors who think that we went too far with the 12,000 beds. It's possible that some have that perception, and that is why we're saying that gradually between 12,000 and 18,000 beds, perhaps there is the means to add a few beds in order to be able to start redoing certain activities, certain surgeries. But the message has always been clear. We're not going to be taking a specialist in a hospital to ask him to fix an emergency situation in a CHSLD, thereby creating an emergency in a hospital. What we're trying to say is that we're taking the fewer or the cases that are not as urgent, we delay them, postpone them when we ask that staff, the orderlies, nurses, and doctors to come and help out in CHSLDs because that is where the national emergency is. That is where we got 850 of the 1,041 deaths. We thought that it would be the opposite. We thought that most deaths would take place in people who didn't come from the residences necessarily, but it's not true. Most of them do come from the residences. You're talking about reopening. You're saying that it's going to be done over a period of a few weeks or months. If we go back to the last pandemic in 2009, the second wave was much more important than the first one. Well, I was very young back then. Yes, so was I. But still, the second wave, and Dr. Arruda will be able to confirm, the second wave was much deadlier than the first. So if we loosen things up, isn't there a risk? What are you going to do to make sure that we don't end up with, overwhelmed in the hospital? That's what Dr. Arruda has said to me very often here and in private, is that we have to go gradually and we have to look and test and look at the evolution according to how we reopen things. And that is why we're saying that it's not a good idea to all go back to school, all 1 million children at school at the same time. We have to go gradually, test, evaluate, see how the situation evolves, and then reopen a little bit more and a little bit more. So we have to go gradually, and in order to avoid the situation of 1918. On the same subject, I'm trying to understand, this summer, will there be vacation? Should parents take it for granted that their children are going to be going to school this summer? Oh, I don't think that there will be school in the summer. Can we reopen the school for some weeks before the end of June? That's possible. But the summer, it's not something that is considered, like July to mid-August, no. Another topic. We heard that there was a guideline from the Minister of the Education to allow some students in nursing to have their diploma directly if they were going to give their time in CHSLDs, which brought a certain level of confusion and concerns from the order. Is that true? And if it is does that respect the requirements of the order? Yes, because there were discussions over many days with the professional orders. So the Order of Nurses of Quebec, of course, it's for graduates where they only had one internship left. So some modalities were planned for, and the order agreed. And we had a ministerial decree on that, and those students can finish their studies and become members of the professional orders. So that was all discussed with the professional orders.
Bonjour. Justin
Trudeau this morning talked about 2 planes that went to recover protective material in China that came back empty. One was going to the federal government and one was going to a province. Was it Quebec? And if it was the case, what are the consequences? No, it wasn't Quebec. Okay, my other question is, yesterday you spoke of the fact that people expressed that they were very tired of being at home. We can see in the United States there's even anti-confinement activities going on. Of course, we don't expect that in Quebec, but are you expecting negative reactions over the next few weeks? Well, you have to really be disconnected to not see that people are tired of being at home. I think denying that would be to deny reality. Now, it's like the lesser of two evils. We don't want those people to all come out at once and start seeing other people, and that the spreading, multiplies over the next few weeks. It's possible, and I've said it often, You can go have a walk, you can keep 2 meters away from other people and wash your hands. So there are ways of leaving the house while respecting certain rules in order to avoid the spread. Now, we'll get to it, but Dr. Arruda said it yesterday. What do we do with homemade masks? Could that help? Could, for example, somebody who is not autonomous and who needs somebody to accompany them, physically, could that person wear a mask when they help that person physically? Those are possibilities that we're looking at, but we're being very prudent before opening things up too quickly. But I get it. I don't want us to end up with huge mental health problems over the next few months. So at some point, slowly we'll have to deconfine.
Merci. Maintenant, une question d'un média qui n'a pas de bureau ici à l'Assemblée nationale, qui provient de Martin Busutil, RNC Média.
So, another question. If we exclude the specific cases of CHSLDs and the Montreal region, the situation does seem visibly to stabilize in the rest of Quebec. Right now, millions of Quebecers are waiting to know more about how things are going to unfold while respecting the isolation rules. You often refer to the better days that are coming up, but in fact, there hasn't been, we haven't talked much about the deconfinement and the recovery of the economy. At one point, are you thinking about mentioning your strategy for deconfinement in more detail? Well, it's quite simply a question of data. We want to be quite sure that things are stable for a certain amount of time. There's no perfect rule. Does it have to be stable for 7 days, for 14 days? I'm looking a little at what's being done in other countries, and it fluctuates from one country to the next. But what we talk about every day is to see when are we going to be ready to have enough assurance on the stability of the situation in order to be able to gradually reopen the economy, the schools, the daycares. It is part of the discussions that we're having every day. Once we're ready to announce a plan, we will, but we're not ready now. Thank you. That completes for the questions in French. Now English.
Good afternoon to all of you. I have a question from my team working for the National. When we compare the province of Quebec with other Canadian provinces, west or east, it seems that Quebec is having a harder time flattening the curve. So basically, other provinces are succeeding a bit better than Quebec. Why do you think we are in front of this situation? I know that you talked a lot about the spring break being earlier, but I have the impression that your reflection is a bit deeper now.
First, we have to compare with large cities because the main problem is in Montreal. So it's true that it's worse in Montreal than in Toronto, but it's a lot worse in New York than in Montreal. It's worse in Paris, in London, in Madrid. It's worse than in Montreal. So there are many reasons for that, but mainly it's because of the people at the beginning who travel or didn't travel and in which countries they travel.
That's the case. In fact, you must look at different factors. Okay, first of all, there is the timing. As I was going to express, in BC, it was cases coming from China. The airplanes from China stops, so the transmission exposition was not as it was in Quebec. If we look at that's the situation of big cities, which are different. If you go to Alberta or small provinces, there is less people, less transmission and everything, and probably less traveling or airports coming from the international. We in Quebec go a lot to France, go a lot to Italy, where there was at that timing probably more people came back with this. And we had the proximity with New York, which is very important. We know that the epidemic in New York just came into Montreal and to Boisbriand community soon. So this is part of a kind of exposition that probably that haven't been done in BC, Alberta, or elsewhere. And we have the specific problem of our CHSLDs. I think it will be interesting to compare which are the volumes of people in CHSLDs in Ontario comparing to Quebec. What are the ratios of personnel? Were they staffed better than we were? That's all kinds of situations that will tell us. And there is this, I would say, virus, very bad one that infect you, and you have no symptoms and can transmit it. So this is the same for other provinces too, but this is part of the equation why this is happening. But I think it will be. We are still having hypotheses. It will be interesting to after really look at the facts, because in fact what was applied in the field, even if there is a recommendation for the provincial, it's always something to look at. So I think those analyses are going to be, I'm sure, done and looked at.
And it's not clear also the number of people dying in long-term residences. Are they declared the same way everywhere in the world? It's not clear.
And we
know that in Quebec we test them, or by epidemiologist references we declare all of them. Is it the case everywhere else?
No. Somewhere it's only a lab-confirmed case. And sometimes they don't do a lot of tests, so they could not confirm that case. And we have this specific situation of what is considered probable elsewhere. Here it's confirmed. It's like if I'm the spouse of a person who died from COVID-19, I've got the same syndrome, and I die. Even if I'm not tested, they're going to be counted as a case. So that can influence at least one part of the difference between the province of Quebec and others, and here in Canada and on the world.
Okay, thank you. Second question. Many people ask you, Mr. Legault, to postpone and basically have the schools closed and get everything starting back over, to have the school to reopen only in September. Now you say, I don't think so. It's not a good idea. I want to understand exactly what are the dangers of having all students going back to school at the same time in September. And then, if you are creating clusters with schools, with regions, don't you have the impression that the danger of this is losing control, and you are at the most delicate stage of the whole operation of reopening the economy?
The key, what I understand, and I'm not a specialist like Mr. Arruda, the key is really to open gradually. So you don't want to have 1 million children going back to school all at the same time. Because then if they contaminate, infect their parents, and that we have a big wave of people needing to be hospitalized, we'll be in trouble. So we have to do that gradually, and every week we have to test the results of this gradual opening. It's true for companies, it's true also for schools. So you have to go gradually, not put all the children and all the workers at the same time on the street.
Thank you. Next question, Samuel Pouliot, CTV News.
Hi. We spoke with a woman whose father is at the Grace Dart facility in Montreal. Her father is healthy and she wants to bring him home, but the facility is telling him that she cannot. Why can't families bring home seniors from CHSLD centers, especially when some families can handle the home care and alleviate the stress on overworked staff?
I don't know this particular case, but what we know is that when somebody is in a CHSLD, it's because he's needing some help from doctors, nurses. So I don't know if they have some at home, but I would have to look at the particular case.
Yeah, I think we would have to look into that situation. because we have told the population that it's possible to have a loved one come back to their home, but there are some conditions and the care also that is required by that person. So we're going to look into that situation.
Next question.
And when things start to get back to normal and people will be using public transit again, do you have any directives for wearing masks?
In fact, if we're going to open it, actually, as I told you, we will probably recommend, if the densification of 2 meters is not possible, that people wear masks. It's going to be, I would say, cover face mask with some recipes. You can find in Health Canada the way to do it. There is the ones that are better than others, but we are going to prepare a video also to make sure that, because it's not in our culture to use masks here like it is in Hong Kong or other countries, but we will recommend that. As I was telling you, if we will recommend it, but we don't forget to wash your hands and to be careful. Don't think that this protection is good for the others, because if you spill, you won't spill on others, but it's not protecting you, and use it by the right way. And we're going to make videos. It's going to be made this week. So people who I think that will be in transportation will have to use masks. It will be better to make sure, especially if you cannot respect the 2 meters. But if you are waiting for going to a grocery and you can have 2 meters in between people, keep it, your 2 meters, keep your mask, but don't try to, because you have a mask, you're going to be 1 feet, one beside the other. It's why it is important, and it's why it's going to be a measure, and we're going to try to make sure that people understand the way they use it, and I will repeat it again, don't forget to wash your hands.
Thank you. The next question is coming from Phil Autier, Montreal Gazette, for Mr. Legault. We are getting questions from teachers about opening schools. Will you impose the 2 meters in classrooms? How will that work at lunch hour in the cafeteria where kids of all ages mingle? How will you protect teachers, especially older teachers, from the virus they can get from children?
I'm not ready to answer this question, but we're looking at different scenarios, and we'll make sure to protect our teachers, for sure. So when we'll be ready, we'll explain exactly what we propose.
Thank you. And now for Mr. Legault and Minister McCann. Yesterday, you said there are 6,000 people missing from the hospitals and CHSLD residences because they are either infected or fear being infected. Can you explain what afraid of being infected means? Can healthcare workers opt to not go to work?
It's a difficult situation, and what we have to stress is that we are providing the protective equipment to everybody. We know that sometimes there have been situations where people were at the last of their protective equipment, and we had to provide very quickly because there is a planning to do in those approvisionnements. But what we have to stress is that we are providing all the protective equipment, and we can understand that some people live some anxiety, the health workers, and that's why we salute them. We salute them because most of them are at work and most of them are helping. So what we're saying is that you should talk with your bureau de santé in your organization, talk with your manager. If there is something that is creating anxiety, and if possible, come back to work with the protective equipment. So most of the workers that are away from work are the workers that are, well, pregnant or immunosupprimés, or have to have a test or have been infected. But there are some that might be afraid, and I invite them to discuss it with their bureau de santé, and I tell them we have all the protective equipment to protect you.
Thank you. Now a question from Raquel Fletcher, Global News. 1 in 5 healthcare workers in Quebec have been declared positive for COVID-19, and we've seen our first death of a healthcare worker in a long-term care residence. You've said yourself many people are afraid to go to work. What is your reflection, your feeling as a leader having to send people into those frightening conditions?
I don't think it's out of 5 workers who have been infected. It's much less than that in proportion. We have 4,000 workers, and we have probably 250,000 workers in the health network, so the proportion is much less. Still, I think about it every day, and I want to support. We want to support very much the workers. I think they are the ones to be saluted. That they go, they treat, they take care of people, and I want to tell them also that we are sending more people to help them, because in CHSLD, in long-term facilities, what's going to be helpful is to have more staff. And we see that we've mentioned today there are workers, there are students, even les entreprises d'économie sociale, they're starting to come in. So there is an effort. So I think that's going to make a difference. And we will also continue to organize teams of prevention of infection. That's very important. This is a new situation. You have to reorganize how you work, and it's more demanding. But as time goes by, we are really supporting better those teams. We are sending people who are experts in prevention of infection. So we're doing everything we can to support them.
And one very last question for Global News. Prime Minister Justin Trudeau was also asked this morning about health workers being forced to reuse personal protective equipment. Is this happening in Quebec? What else can we do to better protect all healthcare workers?
No, I don't think that's happening. Reuse, perhaps when, for the N95, we have now ways to disinfect them. So they can reuse it when it's disinfected. But otherwise, we have the equipment now to give them protection. So there's no question that you don't reuse a mask that is not disinfected. And the only ones that can be disinfected are the N95. And the masques de procédure, you have to throw them out after you've used them. And we have also les visières, that you put in front of your face. The blouses, it's improving. We're going to make blouses in Quebec. We're going to be much more autonomous. We're going to make masks in Quebec. So what I'm saying, and we've made great efforts, the government and the ministry, to really improve the situation in protective equipment. So there's no question you're not reusing equipment that has not been disinfected, and disinfected is the N95, it's possible, and the blouses, some of them will be washable and we'll be able to disinfect them. But otherwise, you don't reuse. And the visière, obviously. The visière you can wash also. But you don't reuse les masques chirurgicaux.
So thank you very much. C'est ce qui complète pour cette conférence.
This completes today's press conference. See everyone tomorrow.